In this video, we're going to talk about abnormal uterine bleeding and the progression to endometrial carcinoma via endometrial hyperplasia and endometrial polyps. Now, endometrial carcinoma is one of those cancers that can be detected really early because it's got a red flag sign. Abnormal uterine bleeding is a red flag for endometrial carcinoma. And what do we mean by abnormal uterine bleeding? In particular, we mean postmenopausal bleeding and abnormal perimenopausal bleeding, because this is when uterine cancer occurs. Another key concept is that unopposed estrogen causes endometrial hyperplasia and carcinoma. And the third key concept that we're going to discuss is that atypical hyperplasia is a precursor to carcinoma. Let's look at these things a bit more. What do we mean by abnormal uterine bleeding? Well, pathologists think of it in three ways related to its cause. The first is dysfunctional uterine bleeding. So there's an abnormality of the normal function, such as an anovulatory cycle, or there's irregular shedding because, for example, inadequate luteal phase means that the corpus luteum isn't developing properly, and therefore the endometrium isn't becoming adequately secretory. The second cause of abnormal uterine bleeding is due to the benign organic lesions such as fibroids, also known as leiomyomas, and adenomyosis, which is where physiologically the endometrial glands penetrate deeply into the smooth muscle of the uterus. The other benign organic lesions, polyps and hyperplasia, can be associated with endometrial carcinoma. And finally, abnormal uterine bleeding is associated with endometrial carcinoma in older women. I know that when you were learning about the physiology of the endometrium, you learned a whole lot of stuff. There were cycles that went like this. There were hormones coming and going. What I want you to remember is two simple messages. Estrogen causes the endometrium to grow and thicken, and progesterone causes it to mature and switches off proliferation of the endometrium. So if there's unopposed estrogen, all the endometrium is getting is grow, grow, grow signals, and it becomes thick. And that's what we call hyperplasia. The glands become large. There's growth without the maturing effect of progesterone. If a woman is given progesterone, either alone or in oral contraceptives, it switches off the endometrium. The two pictures to the right are of approximately the same magnification. The top one is simple hyperplasia. The bottom one is hyperplasia that's been treated by progesterone. You can see that all these glands have been switched off. They've become inactive and small glands, and the stroma's changed as well. It's become pseudo-decidualized as the hormone makes it think that it's coming to the end of the menstrual cycle. Endometrial hyperplasia occurs with unopposed estrogen. And we divide it into two main types: simple, benign hyperplasia and complex hyperplasia that is usually atypical. In simple hyperplasia, the glands are bigger and cystic. We see it on the top right here. They're lined by piled up, i.e. pseudo-stratified cells, which have lots of mitoses in them. But there's no atypia and minimal risk of carcinoma. This is in contrast to atypical hyperplasia. It has a complex pattern with folded glands that you can see in the lower picture. and the cells that line them are dysplastic. About 25% of women who have a hysterectomy because of complex atypical hyperplasia will in fact have endometrial carcinoma. It is a precursor lesion to carcinoma. Let's think about endometrial polyps. They're really common and most are hyperplastic, but they are simple, benign hyperplasia. They're often seen with generalized hyperplasia and are due to an area in the endometrium responding more to the growth of estrogen and not being switched off by the normal amount of progesterone that's present. Microscopically, we see simple hyperplasia in a polypoid formation, those cystic hyperplastic glands in a fibrotic stroma. Endometrial carcinoma is the most common of all the gynecologic cancers, but it's nowhere near as deadly as ovarian cancer, for example. This is because it has that early red flag, abnormal PV bleeding. It affects women over the age of 40, peaking at 60, i.e. in the years after menopause. The unopposed estrogen that causes endometrial carcinoma can come from a wide variety of places. So in younger women around the age of menopause, there are lots of anovulatory cycles which produce lots of estrogen. In contrast, in older women, often the estrogen is the estrogen produced by adipose tissue. So endometrial carcinoma is much more common in women who are overweight, have a high BMI. Sometimes, if we give estrogens, and in particular tamoxifen, which acts as a partial agonist in the endometrium, this can make it grow. The key words to describe endometrial carcinoma histologically are malignant glands invading the myometrium. Whether or not a woman survives endometrial cancer depends on the stage. Like many cancers, low stage means good survival. In cancers that are confined to the uterus, stage 1, there's a 92% 5-year survival. This drops to about 50% once it's spread outside the uterus and into the pelvis. The key message here is, again, recognize the red flag. Encourage women to get that abnormal uterine bleeding investigated. So back to those key concepts. Once again, abnormal uterine bleeding is a red flag for endometrial carcinoma. Unopposed estrogen gives growth signals to the endometrium and causes hyperplasia and eventually will cause carcinoma. Atypical hyperplasia is the precursor lesion to carcinoma. Endometrial carcinoma does well if detected early, and there are populations in New Zealand who don't present early with abnormal bleeding. Help your Maori and Pacific patients to talk about abnormal uterine bleeding. It can save their lives. They have the worst survival of all endometrial cancer patients in New Zealand.